Hello everyone. Welcome to Eye Care with Dr. Bartles. I'm Noreen Zarell, your host, and to my right is Dr. Bartles. And welcome again.
Thank you for having me again.
And we're continuing on in this series, and this is going to be a very important segment. So let's get started.
Okay, we're going to start off with age-related macular degeneration. In our previous episode, we were talking about nutrition and how I feel that nutrition is really essential for health, not just for eye health, but for health of everything. And it's a good lead-in to discuss macular degeneration. Now, most people have heard of it. Many people who have had a parent or a loved one, it can be a very devastating disease. And quite frankly, everybody is terrified by it. So when you mention the word in an eye exam, degeneration, that strikes fear into the hearts of everybody. Yeah. And there's lots of different types of degenerations that are not macular degeneration, but macular degeneration is what we're going to talk about. So in the back of the eye, the sensory portion of the eye is called the retina. That's where all the photoreceptors are. That's where we see. Light comes in, stimulates the photoreceptors, the message is sent up to the brain interprets that into vision, okay? In the center of the retina, there is a spot that has the highest concentration of photoreceptors. That's called the macula. Okay, the macula is also the thinnest part of the retina, and it has a lot of blood vessels underneath in the tissue below the retina. Okay, there are two types of macular degenerations. Okay, there's what we call a dry macular degeneration and a wet type. And the two are a little bit different in each other. In the dry, which if you're going to choose one to have, that's the one you want to have. When we look into the eye, we will see some changes in the coloration back there. And this is one of these things where if you look at enough of eyes, you know what looks good and what doesn't. Mm-hmm. And so in a routine examination, we always look at the macula, and we always make a decision, does this look good, does this not look good? Okay, when it doesn't look good, then we may do some more extensive testing. But macular degeneration that is dry just means that very slowly the pigment cells are starting to break up. It progresses very slowly throughout life, and the changes, the vision changes, are relatively slow, and it doesn't get all that bad. Your vision will deteriorate, but it's not going to be to a point where you can't function. We're going to say, okay, we're taking your license away because you can't safely operate a motor vehicle. Now, the other type of degeneration is wet macular degeneration, and this is much more devastating to vision. Now, what happens here is blood vessels underneath the retina start to break and leak, and the blood and fluid starts to percolate up through the retina, affecting the cells, and causes a lot of breakdown of the cells. So that does cost vision. So we have to be very careful about that. Now, in real life, there is a percentage of dry macular degeneration patients that will transfer to wet. And when we diagnose wet macular degeneration, we have to take care of that very quickly. So that's when you have wet, immediate referral to the retina specialists. Retina specialist may treat with injections. At one time it was laser.
Oh.
Okay, laser wasn't the ideal way of doing it because with the laser, what you did was you went in to close the leaking blood vessels, and there's going to be some collateral damage. Okay, so that means good, healthy tissue is going to be hit by the laser as well as the target. So with the advent of injections, the new medications know where to go and take care of the problem, and we can hold deterioration of vision. Okay, the problem is that the medication doesn't last forever, so it's not a one-shot deal. Okay, a lot of people don't like the concept of having an injection into their eyeball, but it's necessary, and it does work, but it doesn't last forever, and there are patients that have to go back on a monthly basis to get re-upped with the medication. It's expensive, it's time-consuming, but the alternative is to have the lights go out, so we don't want that. Okay.
Is this something that happens in your older age, or do you see any young people say in their 30s and 40s.
We have
having
had
this.
cases of, we've discovered it at that time. And there are times when you will look into the eye and you will see a color change in the back, and you have to start thinking that this is what's going on. And so these patients we're going to watch a lot closer. Okay, so people always ask me, well, what can I do about this? Okay, and I think lifestyle and nutrition is key. Okay, so, and this should be probably said for everyone, okay? You got to knock off the smoking, okay? Because smoking is going to be implicated, and this is first-hand, second-hand smoke, okay? Smoking is implicated in lots of diseases, lots of eye diseases. So first thing is, we say, got to give up the smoking. And we might want to talk quickly about the e-cigarettes. Okay, it's just as bad. Okay, so regardless of what anybody tells you, say, oh, I'm not smoking tobacco, I'm doing the e-cigs or the vaping. Okay, forget it. Okay, can't do that. Okay, nutrition is big in macular degeneration. Okay, so besides smoking, you have to eat your green leafy vegetables.
Oh, it's the green ones.
Yep.
What about carrots?
Well, carrots are high in vitamin A.
Okay.
Okay, and I'm going to risk this, okay, because I can't live with myself if I don't. Okay, have you ever seen a rabbit wear glasses?
No.
No, but seriously, vitamin A is essential for the eye to function correctly. You can overdose on vitamin A, so you don't want to go out there and eat a bottle of vitamin A tablets every day. But carrots provide beta-carotene, which is a good nutrient for the eye. Now, here's another interesting thing with supplements. Okay, if you're a smoker or subject to secondhand smoke, you really don't want to be taking beta-carotene because that has been linked to lung cancer. So here we are trying to, again, treat one thing, causing a problem in another aspect. So the rule of thumb is, you don't self-medicate, you don't self-treat, because you can be doing the totally wrong thing. Let someone guide you. I think that is the appropriate thing. So we talked about green leafy vegetables.
Yep.
Okay.
They're important.
Should always wear sunglasses. Okay, because ultraviolet radiation has been known to contribute to macular degeneration. And to take that one step further, because I'm always up here harping about blue light.
Yep.
Okay, blue light penetrates into the back of the eye. Blue light can stimulate certain chemicals that are there present to do some damage inside the eye. So again, we have to be protective of ultraviolet and blue light. Okay, I'll say it again, knock off the smoking. Okay, and that is pretty much macular degeneration. Another condition that we treat a lot of is glaucoma. Now, everybody knows glaucoma is bad. Nobody knows what glaucoma is unless you have it, or unless we're following you for it. But let's talk a little bit about that. Okay, in the front 1/3 of the eye, we have a lot of space that is filled with a very watery fluid. It's called the aqueous. There's a part of the eye that produces it. There's a part of the eye that drains it. Okay, so we have a faucet and a drain. And there's no feedback system built in between the faucet and the drain, so if the faucet gets turned on a little faster, the drain is not going to open wider. So you get an excess of fluid, pressure inside the eye rises. Sometimes the drain can get clogged. The faucet doesn't shut off. So again, we get a higher pressure inside the eye. The fluid pressure builds up. Okay, if the fluid pressure is allowed to get too high, what will happen is that pressure will be put on the optic nerve, on the blood vessels inside the optic nerve. Nutrition will be compromised amongst the nerve fibers, the 120 million of them that are in the optic nerve, and they'll start to die. What will happen is we'll get blind spots. Now, the first ones that go are going to be out in your peripheral vision. You're not going to notice that they're going to go because this is a very slow, progressive condition. And so we can't rely on a patient to say, I think my vision's changing, I might have glaucoma, because if that's the case, by the time you realize you've had a problem, you're too far gone. So again, you need the unbiased third party to look inside the eyes. Now, because we spend all day looking inside people's eyes, we know what's good and what's not. So there's two things that we do in a routine examination besides looking for family history. But we will measure the pressure inside the eye. Okay, and there's a lot of different ways of doing it. We can blow air, we can put numbing drops in and actually rest a gauge on the eye to measure the pressure. And the other thing that we do is we visually inspect the optic nerve. Because what happens in glaucoma is there's a sort of a central depression in the optic nerve. We call it the optic cup. Okay, in glaucoma, this optic cup gets bigger over time. And so if you start to see there's a change, we have to address it. Now, again, back in the good old days, 20 years and before, patients came in for an eye exam, he measured the pressure. If the pressure was high, he would say, whoops, this is glaucoma, let's treat it. Okay, again, back in the early days of treating glaucoma, the medications that we used to treat it were very harsh, and they caused a lot of other problems in the eye. Now we have much more friendly medications, the dosage is much less. It just is an easier system. But we don't just rely on one test to diagnose and treat glaucoma. There's a variety of them. We monitor pressure. Okay, we monitor the physical appearance of the optic nerve. But technology has advanced and we have other tests. We can measure a person's visual field or peripheral vision and actually look for blind spots. And if we find them, then we know we had better do something. Okay, this allows us to manage the condition also, because if the blind spots are getting bigger, then we know we're not doing a good enough job taking care of this eye. Also, we have another test we call the OCT. Okay, it's basically a tomographer that will go in, it will scan the optic nerve, and it will actually measure the thickness of the nerve fibers. And so if we know from normal anatomy, if there's an area of the optic nerve that the fibers are thinning, we know that's going to be a problem. If there's a corresponding visual field defect, then this is glaucoma, let's treat it. And most of the drops that we do today are once a day dosage, twice a day dosage. Sometimes what you have to do is mix and match medications for the particular individual, because one drop that works great for patient A is not going to work at all for patient B. And so a lot of this, there's some trial and error that goes into it. You know, it's a very hard, fast science, I would say, in detection. But once you've detected it, as far as treating goes, there's wiggle room. Okay, there are risk factors in glaucoma that we assess for a patient. One of the big ones is family history. Okay, if your parents had glaucoma, then you are at a higher risk. If you have a sibling who is treated for glaucoma, you're at a much higher risk.
I thought glaucoma, though, was something that you would see in your over 50, 60,
Okay.
that age range.
My youngest patient that I have diagnosed and treated has been 19.
Oh, wow.
And you find them because you look for it. But it's not an old people's disease. We used to believe it was an old people's disease. But our detection is better. Our knowledge of the disease is better. So when you have your 80-year-old patient sitting in your exam chair, you're looking into their optic nerve and you say, yipes, this is glaucoma. We know this didn't happen a week ago. This has been festering inside that eye for quite a while. So our goal is, you know, providing good, healthy vision for as long as the patient needs to see. And so we start looking earlier for these conditions because they're easier to manage if you catch early stage glaucoma versus end stage glaucoma. Okay, so as we said about the risk factors, okay, family history.
Family history.
Okay, medications can cause glaucoma.
Really?
Okay, people take steroids as anti-inflammatories, and steroids are a great drug. Okay, but some people, they're what we call steroid responders. Okay, and what that means is steroids can raise the pressure inside the eye dramatically, very quickly. And so also long-term use of steroids can lead to glaucoma. So we have to be careful with that. Race is also a factor. Okay, African Americans are higher at risk than, say, a Scandinavian. Okay, also people who are African American from the Caribbean. Okay, so now they have African American ancestry, Caribbean ancestry, they're the worst. And so those should be, those folks should be checked quite often because we'll find it at a higher, at a higher rate. And so the next thing on our list to discuss is cataracts. Okay, because lately I have been noticing that I've had a lot of patients in to see me who are terrified about cataracts. And if you remember, again, back in the old days, 20 years and beyond, cataracts used to be a very traumatic condition, actually for both the doctor and the patient, but it required hospital stays, sometimes a very long time, with your heads being in sandbags so to restrict movement. And that might have been a patient's grandparent but they vividly remember that. And that is really scary. And today's, the surgeries involved are a lot less invasive, a lot easier. It still is major surgery, so we don't want to make light of it and say, this is a very simple procedure. Let's do it when you're 25 and get it over with. But when it is appropriate, and appropriate is relative, okay? At one time, you would diagnose a patient with cataracts and they would say, do whatever it takes to keep me away from the surgeon. And you would change glasses to a point where you finally would say, we can't help you anymore, okay? Nowadays, we start to see a little bit of cataract is starting to affect the patient's vision. Let's get it out. Because with the newer techniques, a younger cataract is easier to extract than an aged cataract. So let's not make people suffer. And so I recommend surgery at an earlier age now when we see that we can benefit the patient. Another thing is there was a study that was done a few years ago in England where they assessed the geriatric population. And what they discovered, okay, is one of these things where I say, why didn't I think of this? But they discovered that people who have had cataract surgery had a lower incident of broken hip. And we all know that for the elderly, when you get a broken hip, that's...
You're done.
My mother would say, that's curtains.
Yeah.
So you stop and think about it. Okay, if you see better, you might not step off a 2-inch curb that you weren't expecting to. And when you're 10 years old, you fall down a flight of stairs and laugh about it. And when you're 75, 80, maybe your body's not going to withstand the shock.
It's a big difference.
So again, we look at risk factors for cataracts. Age is the biggest risk factor. Honestly, if you stick around long enough, you're going to develop cataracts. So it's not a disease, it's a age-related thing. But there are certain lifestyle habits and certain conditions that will hasten the onset. And so smoking, going back to smoking, being exposed to ultraviolet light without appropriate protection will hasten the development. Diabetes is going to hasten the development of cataracts. Okay, you've heard of diabetic cataracts. Okay, chances are if you're diabetic, you will probably develop cataracts 10 years sooner than if you were non-diabetic. So it behooves all of us to take care of ourselves. And so now let's hit on diabetes and diabetic retinopathy. Okay, we said that diabetes is an epidemic. There's a lot of it around. Okay, why as an eye doctor do we care? Okay, isn't that the internist's problem? Okay, but diabetic retinopathy, okay, which means bleeding in the back of the eye, okay, can be very devastating, it's sight robbing, and it's one of the leading causes of blindness in our country.
Oh.
A lot of it is preventable, okay? All we have to do is look inside, okay? Which is why diabetics, we recommend once a year. A lot of insurance companies will demand that their diabetics go to the eye doctors once a year so we can look inside. Okay, if you see there is an issue, you can manage it. You might talk with the endocrinologist and say, we need a little bit tighter control here. Or get to the point where we're saying we have to go and get a retinal consult because maybe we need to go and laser these blood vessels shut. And although I also noticed that a lot of our retina specialists now are using an injectable even for diabetic retinopathy. So that pretty much ran the life of the eye from birth up until the 60 to 80 range. What do you think about the future?
I don't know.
I think that this is it's a wonderful time to be an eye doctor, because there's a lot more things we can do to help patients. But if you look to the future, there are some procedures and developments that are just below the horizon that in a very short time are going to be fairly commonplace. So let's hit on a couple of those.
Okay.
I think it's really interesting. One of the things is, how can we get people to see better? Okay, the lens manufacturers are constantly working on new materials and new designs of lenses that will enable people to focus better. But one of the new things is going on, and this goes back to technology that was learned from laser vision correction. Originally, when we did LASIK, we made the flap, we pretty much reshaped the cornea into a new lens that changed prescription. Then, with higher technology, computer-driven technology, which is called higher aberration ablation. I know, big fancy words, but it's like polishing the lens that was cut into the eye. So now you got rid of visual defects by smoothing it out with the laser. So now they're developing what they call these little devices that will actually examine an eye, okay, and look for the defects, map the defects, and then guide a computer to grind a lens that is custom made to help these defects. And so we're getting into third order eyeglass lenses, and that will also be carried over into contacts. There's always new contact lens materials being developed, new designs of lenses. The bifocal lenses that we use today are much better than they were 10 or 15 years ago. So again, the people who tried bifocal lenses, and now it's 10 years down the road because they failed miserably with them because they weren't the best lenses. Maybe we deserve another shot with that. Okay, some of the new things in contact lenses are being able to deliver medications to patients. Okay, we are treating people for glaucoma with eye drops. Some of us can't put eye drops in very well. Okay, some of us might not have anybody at home to help with the eye drops. So maybe we can get a contact lens, place it on the eye. And this lens will just drip out the medication as opposed. And once a month you go in and change the lens.
Change the lens. Wow.
Cataract surgery, we are getting new implants to see better. Okay, there are new medications. There are newer glaucoma surgeries to help if medication won't help. And the final thing that I'm going to say here is this is really predicting the future, because this is a Tad Bartles view of the future. People with floaters, do we say, well, you know, your vitreous has just got all this in there. I am predicting that very shortly the retina vitreous specialist will go and siphon out the vitreous and re-inject it with a oil or a similar fluid that is not going to react with the body, that'll be nice and clear, and we'll get rid of our floaters.
Get rid of our floaters.
And so that's it. That's
that'd
from
be
birth
great.
to present, and a
Wow.
little bit into the future.
And that's been quite a journey. We're almost out of time, but this has been quite a journey. I hope the audience, those of you that have been with us on this, have enjoyed this particular series. It's been very interesting, and I thank Tad for coming and giving us an eyeball look into the future.
Well, it's
from
been a
the
great
past.
ride. I thoroughly enjoyed myself. Thank you, Noreen, for allowing me to do this.
And thank you, and thanks everyone for watching.